So we are officially recording it on board. Uh, and I wish more people were here because it's one of my favorite lectures to give. And I had some extra stuff to show you with it. Nevertheless, I sent you out. I sent it to everybody, obviously. Whenever you have to make an alteration in your syllabus, and you see the way, and I have to justify it in my mind, there's this idea of I never drop the lowest grade. A lot of professors do, honestly. For me, and my logic is most of you are in fields where you don't have the luxury of saying, well, I didn't do well on that one, but I'll do great on the next. Mistakes follow you around, unfortunately, when you're dealing with people. As I like to say, when you start to take sharp objects or lay hands on people, you got to be careful. And a lot of you, that's what you're in for. Okay, just saying. The extraordinary circumstance of the lab, thankfully coming to an end from your perspective, then to me that justified in my mind. So my wife, did I tell you she made this again? So that's what we're doing. So everybody got that. So I mean, it's like that. Everybody will benefit by it. He was okay. That's benefit number one. That's done. I sent you this little, tidbit. Okay. Now you got an unexpected reprieve. Oh, bonus would be a better word. We are in what's called a core course. Okay. So there's certain courses in our division, in science division, that are designated a core. Principles of biology, the lab, A&P, lecture A&P lab. So we ask the students, we respectfully ask the students to complete this Google Doc form. You'll see it, it's easy. All the results go to me. We are permitted to offer an incentive because we want to get the results. Understand, for a university, any university in and around this area, it doesn't matter, college, university, whatever, and there's minimal distinction. It's certification by something called middle states. Maybe they do it for the high schools as well. I don't know. But universities and colleges are all middle state certification. This is the kind of hoops that you have to go through because they certify every 4 years and every 2 years they do a pre-thing. I'm not involved with this part of it. So this is just a general assessment vis-a-vis science. This is what I'm thinking. The next exam is going to be the 29th. I'm probably marked that under. So let's say since this next exam you got a C plus. Okay. You fill this out, then only if that C plus would magically become a B minus. You would get one little mini grade. One time deal only. Only those people who fill this. I will know because these people. You can't have it. You don't do it. I'm not allowed to do that. Are we good with that? Fill it the F out, please. I'm sorry. I'm still shocked only 6 people in our survivor pool. I thought more people would pick the Eagles. Oh, why didn't they? They terrible last night. Oh my goodness. All right. So that's the announcements are done and dusted. Let us move on. So that's everything I really have to show you. You all got this. You see the link. Get it done. So now we can move on. And you'll see that I've incorporated this fracture images thing in the portion of this discussion. So let's begin with that vis-a-vis the PowerPoint, kind of where we left off. Voila. And I'm trying to do as little bad artwork as possible and talk more about it. I spent 2 years in an inner city hospital, not a big hospital, a couple hundred beds, in Philadelphia as a general orthopedic resident. We saw more trauma than you can imagine. It's in the movies. Cars would pull up to the emergency room, throw them out. They throw somebody out, the car would drive off, gunshot wound, stab wound, broken bones, just name it. So they say about life imitating art. I mean, people who do these doctor shows, they have medical consultants, and it's not just me. Any doctor who did, residency in a hospital, basically we have a ton of great war stories. Some of them are forthcoming. So I spent 25 years treating a lot of fractures for adults and children. Not so much in the emergency aspect anymore. That became more limited when you're in private practice. And I didn't attend an emergency. In other words, I wasn't on call for an emergency room after my residency. So, and again, we spoke about this. Again, what are fractures? Any interruption in the integrity of the bone. Okay. And again, mostly from trauma when you're young, mostly from weakness in bone due to bone thinning or other problems. And you see some slides of this. This is the classification. Okay. The one, and the one I didn't put up there was like complete versus what I'm demonstrating here with these sort of geometric diagrams, block diagrams. That would be a simple, that would be a relatively, that would be a complete fracture. It goes all the way through. You can see here. So we have a fracture line. Thank you. I don't know pull it up. It goes all the way through like that. That's complete. I could have drawn it differently, something like this, just for demonstration purposes. And this would have been an incomplete fracture. And it could have been this way, it could have been that way. So the distinction between complete and incomplete is it what we call through and through, or incomplete, not broken all the way through. And there's a distinction between those that we'll get to, between what happens in growing bone and what happens in adult bone. In adult bone, clearly incomplete. Wait, and it's not that you're going to have to describe any of these. I'm trying to give you an idea. If you're in a clinical thing and you have a chart in front of you, or these days I'm sure, computerized in front of you, and you're able to read an X-ray report or an imaging report, you should be able to visualize in your mind what it means. That's how clear and distinct they have to be. So that's important. When they talk about displaced, you see this is a little over here. Certainly this is not written by an orthopedic surgeon or practitioner or anything. Ends retained, displacement is not that. Displacement, I'll buy that it's not in the normal position. But there's two terms that are used. And that's why I wrote them here, just in case you see those going forward. Again, I'm not going to show you a picture of a fracture. Ask you to tell me what it is. Not going to do it. So this is, so here, if it's just through and through and the bones are sitting there, it's not displaced. If they're split apart, they're displaced. Displaced can be width, displaced can be, less contact or no contact at all. This is what we call angulated, and it might be both. These could be quite a ways apart. You have something that's angulated, and you describe it. The distal segment is at a 30-degree angle to the usual orientation of the long axis. Right? So I want you to understand that's where terminology comes from. And my radiology professor basically got up there and was sitting in a dark room looking at X-ray after X-ray, trying to stay awake. I don't like here. That's why the lights are on. That basically to understand and using the appropriate language. So it's more for you to, going forward, for you to be able to sort of use the same technique to identify it. The single most important open or close. Very important. Open means this. Not just the skin is penetrated, but that's certainly, that's a little too big. Effectively, the way I describe it, the bone has been exposed to air. Once bone has been exposed to air, whether you just an accident at home, you fell, a piece of skin came up, and all of a sudden you're seeing bone shining through it, or there's actually a fracture, something penetrating, sticking out. Or maybe there was something sticking out. Because a lot of times when you twist your ankle really badly, you hear that snap from people. All of a sudden it'll go through and they'll immediately try to guard and protect it. They'll reflex, go backwards and go back. Effectively, you'll have an opening, the bone was there. You actually have to probe those sterilely to see if you can feel bone, depending how deep it is. Is it just a superficial, just on the skin, or deeper? Once the bone's been out or exposed in any way, even if you stubbed your toe real bad and the nail came off, and that nail bed that I'm sure you went over with Dr. Robbins in lab, that nail bed was lacerated. There was a cut. Bone's right under it. There ain't nothing in between. That's an open fracture. By definition, that bone is infected, period, in the sentence. It must be treated for infections. It requires not only antibiotics, it requires something else, microbiome, making sure someone is tetanus covered. Open fractures, by definition, burn that into your life. You're unfortunate to have me for micro. Please don't. I like to have just 5 people in a class and make my life easy. Lucky 6. Okay. We talk about this endlessly. That's really important stuff because everything is different. You have to deal with the infection. You can't do all those neat things. I mean, that arm could be flipped around backwards. That foot could be pointing that way. As long as the skin is intact, you have the luxury of going in there, and that's what's called a closed fracture, and doing what's necessary. Because if you open it up, then you're in a controlled environment like an operating room, and you can operate. Once it's an open fracture, now you have to address the infection first before you can really fix it. You have to make sure that there isn't a lot of infection, and you have to be very cautious of what you would do. I'm sure the technology has changed than when I was introduced to this 50 years ago. Obviously, it has. But we did things like putting people in traction and all that type of stuff. The very first night I worked as a resident, not the attending, in emergency room, and I was covering because I was a junior resident. It was supposed to only be a senior resident who was doing this. In about 20 minutes, things go crazy. It's like if you watch that show, The Pit. That was very realistic. It goes from everything's nice and quiet to all of a sudden all hell breaks loose. I had 2 open femur fractures, femur sticking out. Guy fell off roof, tarring a roof, Philadelphia, probably an old flat roof. Part of his femur, a couple of inches, some of it covered in tar. Ouch. Older man. The other guy was a guy working at a pizza shop. Okay. And he came in screaming and yelling and holding his leg. Oh, I've been shot. We couldn't see anything because the way they brought him in on the stretcher. And I'm like, I'm there. I'm like, screaming. He's shot. You couldn't get near him. Finally, we started to, and I said, look, we've got to get his pants off and take a look at this thing. Started to lift up his leg. He's screaming. I see the blood. That's when you cut off the clothes. Then it's just easier. You're not going to save him anyway. And I see a big gunshot wound, and obviously the bone's been affected. Oh my God. That was a long night. I think I started the shift at 2 in the afternoon, and I probably didn't get home till 6 in the morning. And I remember the last thing when my attending came in, and he was leaving about 2 in the afternoon because he had to operate on both these guys and put pins in and hold them in traction. That's what he did because they were all infected. He goes, I said, what orders do you have? He said, Lou, I want you to write every order you can think of on that chart. I knew how to respond to him. Yes, sir. Yeah, I know. I'm calling up neurosurgeons in the middle of the night because we suspected concussion. I'm calling up infectious disease specialties at 2 in the morning. Oh my God. So that's the kind of wild stuff that goes on. True story. And every doctor has them if they've done stuff like that. It's not designed to impress you. It's just the way it works. I got a lot of experience because my first wife was the head nurse in the emergency room. She was assistant head nurse at that point, and later became the head nurse in the emergency room. It was kind of neat to see somebody who was barely 5 feet and a half inch tall. When she was there, the first night I came in to pick her up, at the end of her shift, we were just dating. In an emergency room, all of a sudden somebody coded, in other words, cardiac arrest, and see this little girl scream, whatever we call it, the code 99 or whatever it is, red blanket, but there's a lot of different terms. We call it code 99. Jump up on top of this guy, literally on top, straddling this guy's chest, pound it, what we used to call a precordial thump, and start pumping. I'm like, we're into action. So it's pretty cool. That's why I like giving the lecture, to understand there's so much to this. Let's get on with the part of it. Different ways fracture. So what you typical fracture that you see, let's assume it's something, if we took it just like this. Let's say we drew another Just put a fracture line through it. That's a complete fracture. It's in alignment. It's not displaced. It's not angulated. Okay. Assume it's closed for argument's sake. Nothing special there. So you have one fracture line. You have two fragments. If you have more than one fracture line, you're going to have more than two fragments. By definition, that is called a comminuted fracture. Bone fragments of three or more pieces. This is not an elderly person, by the way. But typically, this is the kind of thing. You can imagine a car bumper nail on somewhere like this. Look at the position. You have distal tibia and fibula. That's the kind of thing. So yeah, is it more common when bones are more brittle? I'll buy that. You don't want to think about that. So you have to judge it by what you see. So that is comminuted. The words comminuted and compound do not necessarily go together. If that happens to be, if the bone had broken through the skin or the bone had been exposed to the air, now you have a different one. Comminuted compound fracture, distal tibia and fibula. Now, and then you go on to describe what's going on. This is in pretty good looking alignment. Why I don't think it's elderly, I don't see any osteoarthritis. As opposed to this is a classic compression fracture where the bone gives way, and you can see how washed out that bone is. So the vertebrae crush, and effectively what happens is it induces the disc, depending on the mechanics about it, to bulge or change. And effectively what causes the big set of problems to me initially is it alters the opening there. That is your vertebral foramen. Because that's where the nerves exit. And so and they are more common than you think. As people get older, we get a lot of those. That's why my first wife, I mean, she wasn't told she had terrible osteoporosis. I use her for an example with her permission. She's so diminutive to start. She had a lot of the risk factors. We'll go on, which we cover that. And probably 2 inches shorter. She'll be 75 in January. Okay. It's all right. She just got new furniture in her apartment. She's happy. We're all on the same thread with all the grandchildren, great grandchildren pictures. Everybody's a happy dance. So it's not limited to this. This is the definition of what's called a pathological fracture. Pathological means there's some disease entity. It could have been a tumor. It could have been an infection. It could have been any bone disease. And here, in this case, it's probably the most common of all the bone diseases, osteoporosis, that caused it. So the bone crushes with result of this. And here's the comminuted. And again, these are unlikely to be open. These may be. Extremities, you have to be watchful for things like that. Skull fractures too, probably. This is a spiral fracture. Now, if you go back to that, the Welsh Hull, your textbook, and I uploaded the document. They have some very nice illustrations of these that are in there that you might want to look at just for context. And so this is where you begin to see that. That's a spot, and it's a twisting. Little clinical clue. This is typically when the foot is stuck. Think of a sport like skiing, when it's in a ski boot, and the person takes a fall, the foot sticks in, and it doesn't give away from skis. And then there's a twisting motion that's involved, or a sport injury where in football or in soccer where the foot gets stuck, and all of a sudden there's a pile up and a twist, rugby, that will lead to that. So this, you can clearly see this is an adult bone where we'll get to this. This is a kid's bone because you can see the growth plates. Here and here, that's a classic growth plate fracture. That's the distal femur being fractured through it. Okay. So that's a spiral fracture. We typically see most of those from sports injuries. What happens if we see them in a little kid? I mean, we're talking about a little kid, 12 years old, 14 years old, less, 10 years old. What should be in the back of your mind if you happen to see that? Pardon me? Could be a playground. Very good. Anything else? Think evil thoughts. It's not Peter Pan. Sir, thank you. Yours is good. It's good. Child abuse too. Short answer, because you both had the right answer, is that we don't know. So when we don't know, and I make a point of this with every class, I'm not being preachy about it, it's not an option. You'll hear me say it if you haven't heard it already. Licenses are very hard to get and very easy to lose. If you suspect that this could be a spiral fracture in a child, is typically we see them upper extremity. Come on, we're going. No, and they won't hold. They'll hold on to that kid. Kid will twist and twist. The next thing you see up here. They grab the kid. They swing. It's not like when you're walking with a little kid. It's 1, 2, 3, swing. At the moment of force doesn't have it. It's not going to dislocate. Shoulder dislocations go along the same way. Little kids do those things. You have to be watchful. So depending on your position, if you are supervising, you are probably obligated to report that, at least to social services. Let them decide. You're not making a value judgment. The problem is, a lot of times, you'll see this in somebody you know. It's the classic, the lady comes in the emergency room. What happened? I fell down a flight of stairs. There's a point where you can only, how many flights of stairs are they going to fall down before we all of a sudden realize this is just an abuse situation going on? And the same thing with a child. What happens if that child 2 weeks later, heaven forbid, goes to another emergency room and they report it and they go back and look at the records, because there's going to be a record, there's going to be insurance, there's going to be records, they're going to investigate and find out where they were, and they find out you didn't, and your name's somewhere on that chart. You are in, not you, everybody, whoever is responsible to report it is in trouble. Period. It is. Now you're having to deal with, why didn't you report? Because the child can't speak for themselves. We are always responsible for the well-being of the child. And you can't presume that, I know this family, they're really nice. Nobody knows what goes on. Sorry. I don't mean to be a mean guy. Here's the anecdote. My daughter, pain in the neck, 14 years old. And you're not the only 14-year-old girl with bipolar disease. And since she got pregnant when she was 15, you can imagine she's a bit of a wild child. Just saying. So one day she is mouthing off to her mom. I nailed her. And unfortunately, I had my wedding ring on. And she had a little, and the school came to the school, and the teacher saw it, and they're obligated to report to social services. So we got a visit from here, CYS, Children Youth Services. They came in, my wife and I were there, my ex at the time, sitting there, and I told them exactly what happened. And she came down. And I mean, she knew she was more ruder to the lady who came, calling her all sorts of names, than she was to her mom. And the lady looked at us and goes, "I'm surprised you didn't kill her." I said, "Well, you want her?" She goes, "No." Not quite like that, but you get the idea. There was no repercussions. That's their job to decide, to evaluate the whole situation. But again, protecting the child. I wasn't mad at the teachers. It's not something that they had. When you don't have an option, there's no way that you can avoid it. It is mandatory. Let the chips. You may lose a friend, but you won't lose your license. And professionally, they're very hard to get back. There's always that stigma. So end the sermon on the mount for this. This is a child's fracture. And remember, I told you the struggle. And maybe they're dramatizing this. This has displaced. Fortunately, they are fairly, I wouldn't say the term easy, but you put under anesthesia and relaxants, the muscles tighten up and you're able to manipulate that back into place. Most of the time, you don't have to use internal hardware with that to hold it. But that's the idea of that. So the structural weak point, there's a whole classification of these fractures that I tell my advanced, and I told them about this. They didn't have to know. But as you get old, as you go on in your careers, particularly if you work in orthopedics or pediatrics, you'll see things like type 1, type 2, or type 3. There's a classification for all these fractures. Doctors classify fractures. We classify tumors, we classify infections, all of this, HIV and things like that, because the classification guides us on treatment. If we know someone has a pancreatic cancer stage 3B, we know exactly what prognosis is most likely to be, what type of chemotherapy or radiation therapy or immunotherapy is indicated, and it's called standard of care, a term you will hear a lot. So you have to, and the standard of care means this is what you're supposed to do unless you have an awfully good reason to do it. And so that's why we classify fractures. The standard of care, let's say, assuming this is an adult, not a problem, we know what kind of hardware you're going to have to put in there, how long it's going to be, and why didn't you do that? That's a question doctors don't want to have to face, and nurses don't want to have to face. Because particularly, I mean, with nurses and someone who's a nurse practitioner making a decision, and that's when, I can't even tell you how many students I've had here over the last, the better part of 20 years who have gone on and gotten their DNPs and, and nurse practitioner status. So it puts you in a different position where you're responsible. You're working under but a lot of times you'll be manning, we have some who, particularly in underserved areas, manning a remote clinic. First one I encountered, we had one, where was it? If you know where Tionesta is, Northwest PA fans, hunting territory. Tionesta is between Oil City on the way to Warren. Not helping you. The only thing is it's the busiest place in the world for 1 week. Bucksies. Then it looks like downtown New York. Just saying. So that's just giving you an idea of those. And it doesn't look like that. It's interesting. This is called the depressed skull fracture. What it does, remember you have that sort of sandwich of bone, cortical, outside cortical, inside cancellous for one of these flat bones. They're representing frontal, obviously, with this. And what happens is it creates a fracture, and the force may not have necessarily, it appears to have fractured both cortices. In other words, you have fractured the external as well as the internal. And obviously what that means is it's going to have it could have created, and perhaps this one most likely created some significant damage inside. And then you have to watch out for them. At the very least, okay, these are the kinds of things, we talk about it a little bit in nervous system. When you're starting to deal with concussions and things like that, head trauma of any type, you have to be very, very cautious that maybe a fracture maybe they didn't appreciate that degree of head trauma when some kid got clunked or an adult got clunked. And there's all sorts of things you have to be watchful for. One, not using strong pain medicine, because that pain is a warning sign. So basically you only can use Tylenol, at least for the first 24 hours. Things and we have to do what's called neurochecks. We have to wake that person. Particularly if it's a little kid's very annoying, like every 15 minutes or 3 times an hour, twice an hour. Are you okay? Yeah, let me sleep. You're doing it for a purpose. Warning sign number 1, cement that in your memories for your own kids and everything else with head trauma. Projectile vomiting. That means intracranial pressure. And if that's the case, get them to an emergency room, not an urgent care. I'm not trying to paint urgent cares. An urgent care diagnosed my wife's Lyme disease during when we had the COVID lockdown. Talk about that in micro. Understand this is something where somebody's going to have to drill a hole to release that pressure. That's a big deal. I'd rather have that in a hospital. Just me. And then this is the incomplete fracture. This is not, always a green stick fracture. Green stick, the analogy is, and why we call it that, is like if you're looking for firewood and you want something that snaps and is brown, if it just cracks and bends and it's green on the inside, it's a green stick. That's where the name. They're called incomplete fractures, like the one I drew up there as an adult. If it's a child, and again, we know it's a child because we can see the growth plate, now we have an incomplete fracture. Just giving you some of the ideas. Now, a lot of times in a true green stick like this, that bone will bend so much that one of the treatments is, and we sometimes would have to do this in emergency, not emergency, but surgery afterwards. You actually have to complete the fracture. You have to put them under anesthesia and snap it completely to realign it. And kids' bones heal great. They just do. Okay. Unless it's something really bizarre, they heal really. The big problem, if I go backwards for you without going crazy about it, is if it goes through the growth plate, if it goes into this part, if that fracture line would have gone down and entered the joint, now we begin to see irregularities in growth. And now you have to sort of be able to predict the future as to, is one side of the bone going to grow irregular or not. Sometimes you have to electively stop growth. There's all sorts of procedures that had to be done. Now, I never had those. If I had a case like that and I didn't, I would have referred that to a pediatric orthopedist, to somebody who, pediatric orthopedic surgeon, who, that was their bailiwick. Because then you're trying to balance out the ends. It's not easy. Around here, we have one of the best children's hospitals in the United States. Same thing. There's one here. Our children's here. Children's in Philadelphia. Great hospitals. Great hospitals. Obviously, when I saw mine, we were in Philadelphia. So, what do we call them? Reduction means to reduce the deformity. That's where the name. Closed is just that. We did a lot of the closed reductions. They were relatively common to do. The ones we saw were usually some type of traumatic incident, and basically we would be able to either under local anesthesia with sedation or general anesthesia, basically you just manipulate it back into place. And sometimes we'd even insert pins. It's called percutaneously. So you're not opening it up, and it's a little less likely to, and if it is infection, it's on the skin, it's much, much less problematic. So effectively it's closed, we're manipulating it. The ones, if you go back and look at like the ankle fracture that you saw initially with all the parts and things like that, now you got to use some type of sophisticated hardware. I'm going to show you some illustrations of that as we continue to secure the ends. Okay. And typically nowadays there's a lot more alternatives to putting somebody in a cast. Originally, we used plaster of Paris. Then it migrated into fiberglass, which I used, and I used both of those. Very familiar with both of those, and they were very, very useful. We're seeing a lot now of more removable. You see people walking around the campus with them all the time. So they may have had a broken bone, but the beauty of that is you can do rehab, you can do skin care. And the whole idea is compliance. Why you put somebody in a cast, a lot of times, particularly for little kids, is compliance. They'll try to, believe me, they'll play sports in the cast, they'll go swimming with the cast, believe me. Seen it all. You're trying to keep the kid down. Please rest. Oh, we'll put him in a cast, maybe that'll help. And so, and again, there's so many variables that if you go into a field like this, you become familiar with it. And that's well stated there. These are the steps in healing. Okay. Basically what happened, and most of the healing again comes from the periosteum, the underlying. It forms, first thing it does is has got so much blood supply, it starts to bleed. And what happens in trauma, it releases a lot of chemicals that begin to induce the blood to start to clot. And remember, it's enveloped by, for the most part, by at least some amount of this periosteum. It's holding it in place. So a hematoma means a large unit. It's like a tumor of blood, but the OMA suffix means tumor, but this is not a tumor in a cancer or non-cancerous sense. Okay, this is just a bunch of blood. I mean, you might have had one under the skin. You call it a blood blister. That's really a kind of hematoma. Nothing unusual about that. And just like I was telling you before, the cells that come from the periosteum and even from the endosteum start to form what we call a fibrocartilaginous callus. So it starts as fiber to begin to knit the ends, then cartilage is laid down, and then eventually we go to a bony callus. And then finally, the bone itself seals and begins to remodel. The amount of time depends on the fracture and the severity and the age and all those other factors, nutrition. Typically, it could be as little as 2 months, and it could be as much as a year. Young, healthy people like you, if you had a really uncomplicated fracture, a year after, you wouldn't even know the bone was broken. It's not, you just, now if they had to put internal hardware in there, that take it out, that's a little different. So here's the torn blood vessels, because it's just so much, this mass of blood, swollen, painful, inflamed, because it's all, your body starts the process of inflammation healing right away. So and a lot of it is lifting up that periosteum. Here's the through and through fracture. Here's the hematoma. And so, again, white blood cells are busy gobbling things up, fibroblasts, collagen to start to hold the ends together. And all these we start. And again, it starts with fibers, then cartilage, then bone. And so this mass, this fibrocartilage callus, callus is something hard. Think of it that way. And so here you begin to see things are starting, and this is kind of what it looks like here. They typically use that blue color in this PowerPoint sequence for callus. And so, and you see this in about a week, about the first 3 days, or this inflammatory phase. Over the next 3 weeks, we see this really form, okay? And it starts roughly about 3 weeks to anywhere, maybe 6 or 8 weeks, is where we see the conversion to a true complete bony callus. That's why that 2-month x-ray is so important. So you really begin to see what's going on. And then at that point, the question is, and really the determination when we take off a cast or take them out of one of those sort of sandwich casts that are removable, is maybe about, depending on what, 4 weeks, 6 weeks, 8 weeks, how much pain there is, can we move around? When really it stops being significant pain, okay, now we can go to weight bearing. Now we can be more aggressive in their rehabilitation. It all depends on where it is and what's involved. There's a lot to it. And here's the bony callus forming. And really the term we used was consolidation, with the watchword being solid. That's in there. And then it remodels. And all that stuff, lay it down here, reconstruct the walls, mechanical stressors, blah, blah, all of a sudden. And it's going to look a little funny. And then, like I said, by about a year, process something we call union, meaning everything is united. Voila. Going back, I'm going to show you some other fracture stuff here. And it's time we have left to save the osteoporosis discussion for Monday, because I think that's something I don't want. It's not going to take us a lot. And we're going to be making that transition to joints after that, undoubtedly, on Monday. But I'll show you what I wanted to. So I found this. I just Googled radiology of fractures or fracture images, and I got this. So I thought that was pretty useful. I'll accept and continue. I'm good like that. So here, transverse fracture of the tibia. And they show you the line. This is I thought it was very concise and neat. So this is describing the fracture line. Is it transverse across? Transverse things are sometimes harder because they're inherently unstable. And they don't have as much surface area as something that's oblique. There's a fifth metatarsal. Fifth metatarsals get broken all the time. I mean, because you whack those the side of your foot, you get whacked. Plus, there's a great big tendon that attach here. To know this, I don't know if you did this, it's called peroneus or fibularis brevis. It is ridiculously strong. It's a big support. So you'll hear with athletes a lot of times, let's say they had a fifth metatarsal fracture, it yanks off, and that's called an avulsion, when they pull off a piece of bone fracture, and that's called a Sir Robert Jones fracture. Oh boy. My soccer team is Manchester United. Sorry. We used to be the best. And there's a player who was on the Argentinian World Cup team, Lisandro Martinez, who's missed about a better part of a year or more because of complications from that particular fracture. Not an easy, they are hard to treat. Sometimes they're very easy to treat, hard to treat. Here's that spiral fracture. Okay. Adult bone, probably sports injury. They call this a sagittal plane fracture. It's hard to see because it's right in here. I mean, and you can't, there you can see it, okay? So sometimes they're a little harder to see. Now, this one went right through the joint. That's a problem. Irregular bone fractures. Here's calcaneus. This undoubtedly was a fall. Okay? So, it's undoubtedly was a fall from a height. You always, when somebody falls from a height, you always x-ray their heels. That's usually what they have. Their back, because the force goes to their back, and inevitably they pitch forward in their wrists. It's like a tripod. So heels, wrists, back. So you always have to make sure with those kinds of things. One of my patients he had a comminuted fracture that was in so many multiple pieces. There was nothing you could, I looked at it and went, oh my God. I don't know where to begin. So all I could do is put him in a cast, a lot of compression because it was swelling, get it elevated, and I called the heel expert. He was either at the time at AGH with Allegheny Health or with UPMC. I think he was at UPMC. I don't know. I don't remember his name. It's a good 30 years ago. And I said, please take a look at this guy. I think it was a truck driver. He was so used to jumping out of the platform of a truck down. When he got out, just one time it hit the wrong way, and oh my God! I think it really limited his career at the end. Thankfully, he wasn't a kid, probably mid-40s to mid-50s when all this happened. Very, very interesting. And so, you can just keep going with these. Here's a comminuted fracture. Look at that one. I don't know how that's nasty. Right? The shoulder area like that. Oh my goodness. So multiple fracture lines and fracture fragments that you can see. And when you start to see things like that, you start thinking about blood supply. Here, metacarpal in your hand. This is another comminuted fracture. It's like they call it a butterfly fragment. The line here is like the one I tried to draw. It's there. Tibia and fibula. Multiple, again, fragment here, fragment here, fragment here. Difficult to work with. You're going to see what they do for them this time. And so this is the displacement, undisplaced or displaced. That's what I was trying to show you. And sometimes they will be shortened mostly. And this is one of the things we do when we want to lengthen or shorten a bone and recreate fractures. Sometimes you want to do scientifically. So lengthening a bone, you can lengthen tendons this way. We use a lot of science behind that. But we'll go into it another time. Maybe I'll show you with joints. Here's the angulational part of it and rotation. So there's all sorts of ways to describe these things that are there. And so here you can see shortening and see angulation where it's bent a little bit to the side. I think that, I'm trying to make the point better than mine. Here's the bone density, pathological fractures. So you're starting to see here, reduced bone density, normal density. Here's the fracture line. Remember, that's the ulna. We did all that. The radius and ulna function as unit, like tibia and fibula. Multiple myeloma. That is a disease of the bone marrow. It's a cancer of the bone marrow. In particular, in the white blood cell line that eventually is responsible for making antibodies. And it's all that. It's a very, most of the time, you have to sterilize the bone marrow. That's fancy, and do bone marrow transplants. Sometimes successful, sometimes it's not. But moth-eaten bones like that you see. Here, now remember, we think, it's a tumor. This is a benign bone lesion. The fact people say tumor and they inherently say, oh, he's got cancer or she's got cancer. No. Tumor is a growth of tissue. The question is it's an abnormal growth of tissue. The question is the tissue abnormal or normal? So, and 90% of all tumors are benign. So don't get into that. I said that to when I had bladder cancer. He goes, you have a tumor in your bladder. Was it benign? Or he goes, in the lining of your bladder, they're all cancer. And I looked up, he's right. He wouldn't tell me a story. And avulsion, so I was talking about, it's like all of a sudden, here's a finger when it just yanks off a little piece of bone. You can't see it so well there. Stress fractures. Typically, it might even take a couple of weeks to see it. We begin to see thickening around certain areas, the periosteum reacting. So sometimes we look for evidence of healing rather than look for evidence of the fracture. And periprosthetic would be, you can see this was a prosthesis. It's like the stem. I'm not sure. It could be the stem of a hip prosthesis or a humerus prosthesis. Okay. Colles fracture. That's when wrists, when the distal radius fractures dorsally like this. Fall, boom, Colles fracture. You fall this way, as older people can't get their hands around, it's called a reverse Colles. Start to look for things like that. I treat a lot of older folks. That's ears, dislocated finger, lovely ankle, fracture dislocation of the ankle, one of those really nasty things. Here's all sorts. I mean, diastasis means that's normally together. Imagine something that caused that to separate irregularly like that. It'd be pretty severe. And see, let me show you some of the hardware. This was okay. These are called K-wires. Rather say Kirschner wires. And this is called cross K-wires. Some of the things you can use that are there. And there's other pins, plates, screws. External fixation has been around. You see this device. It's like clothing. Okay, different kinds of clothing styles go in and out of style. This was what we used to do back in the early 1900s. Then they stopped doing it, and now they found out it's a lot easier to do because you're better off. It's called an external fixture. You folks, if you're going to clinical, you're going to see those. You have to just care for the skin, but you can tighten them and loosen them, and it allows the person so you can evaluate the skin, particularly if they're at risk of the skin breaking down. So it's a lot of good stuff that's there. All right, we'll leave it here. I hope you got something out of this. Let me blab about fractures, one of my favorites. Blabber. Have a great weekend. See everybody Monday.